All right, I'm going to go ahead and get started. I've got a bunch to talk about today. So I gave a talk kind of like this to John and Mario. Y'all asked for it, although I've changed it up a pretty good bit. So, and y'all are my guinea pigs because I have to give it next week to about 500 docs in Las Vegas. It's just terrible. Somebody has to do it though. So I am going to Vegas.
I'm gonna let my husband talk to you. I'll do some sports bets.
Yeah, whatever. All right, so we're going to talk about, that was way too high. We're going to talk about some advances in preterm labor and diagnosis of preterm labor. And so this is a great quality kind of talk. That's better right there. We'll talk about fetal fibronectin. We'll talk about a number of different things here. I have done research just in the past. I think you have to do these for a year. So both of these people in the past. None of that has anything to do with preterm labor though. So learning objectives are understand the risk factors associated with preterm birth. So we'll talk more about that. We'll talk a little bit about the efficacy of some diagnostic tools and then also talk about some strategies and how to use this in labor and delivery every day. So this is the latest data from the March of Dimes, and every year the March of Dimes gives out report cards. So they used to call them report cards. They don't do that anymore. So I guess that's not politically correct. And you know, every organization now has to be politically correct. So it used to be ABCDF, and then it was ABCDE. I don't know. And then they quit that, and then they broke it down like this. And so the good thing that Alabama and Louisiana have is that we always can point to Mississippi as the highest in prematurity birth rate, and pretty much everything. And Betcher's in the back, yeah. So I always seem to migrate down this way just because you know, it's job security. I don't have to worry about my job. So, and I think Louisiana's is 13.8 or 13.7. And they've actually been told, is my understanding, that they're going to feds are going to decrease the amount of money they send them next year if they don't do something about this. So the new Secretary of Health has got a task force, and Dr. Bokini needs a faculty member to volunteer to be on that task force. So I volunteered McCaffrey, and he's real interested in this. I'm kidding. All right, so this is one of those graphs that's been around forever, and you know, whenever I saw this a long time ago, in that March of Dimes 2020, that goal, and this data stopped at 2011, I thought that was not a possibility, but it actually probably will happen. We are seeing a decrease. A lot of it is iatrogenic. I'm not going to get off into that today. But I can assure you, every time you decide to deliver a baby prematurely, it's probably going to be looked at both at an insurance level and possibly even in some states at a state licensure level. And I won't get off into that today, but it has made a big impact on the rate of preterm delivery across the United States. And in some states, it's been dramatic. So we know preterm birth has a lot of increased morbidity and mortality, and anything that happens to a term baby is much worse than a preterm baby, and we probably all know that. And unfortunately, we deliver babies here in this institution not infrequently that will ultimately cost us acutely $500,000 to get them out of the hospital, and then the long-term cost is markedly more than that because these children have lots and lots and lots of problems, and they eat up a lot of health care dollars day in and day out. The last time that this was done, and this is from the ACOG Technical Bulletin, or Practice Bulletin on Prematurity, which hadn't been changed in a few years, but this is 95 data, or excuse me, 2005 data, and the average cost of a preterm baby is about 10 times higher than the cost of a term baby, and that number really probably has gone up and not down. We spent in 2005, that's 10 years ago, $26 billion in that year on prematurity. That's a lot of money. So So really part of the problem is that like a lot of things in medicine, we've looked at preterm birth as a specific problem and not realize that it's really a constitutional, it's a very complex process that has a lot of mechanisms that initiate it. And we'll get into that in just a minute. And so this is a statement, and there's a book that's actually the cover of a book. I have a copy of it. I think it's at home still in the box somewhere. But it's from the National Institute, from the Institute of Medicine. And they basically just say there's not going to be a silver bullet out there. We're not going to have one drug that's probably going to take care of this problem. And we'll get into that and get into the specifics of that a little bit more as we go forward today. But it's a lot of different disease processes. And it's because it's a lot of different disease processes, what we really should be looking for, and I'm going to give you a list of them in just a minute, we should be looking for markers for each one of those disease processes and then hopefully have a specific treatment for each one of those markers. And that's kind of what we have with cervical length, and we'll talk about that a little bit later. But an example will be IL-6. There are companies out there that have vaginal swabs for IL-6 that are highly predictive of positive amniotic fluid specimens. The real problem becomes, how's it going to change my management? And that's the thing that we haven't been able to really see or change the outcome. And so that's the reason why they haven't really gained a lot of popularity across the United States. So Roberto Romero gave me this slide probably 5 years ago now then. He's probably done more work on this than anybody else. And it basically, he breaks prematurity down into a number of different disease processes, infection, and I hope the residents know that infection, if the earlier in gestational age somebody comes in preterm labor, that really is preterm labor, and we'll get into that in just a little while, the more likely it is to be infection. And when you get down to 24 weeks, it's more than 50%. Okay, so when they come into preterm labor, infection becomes a big issue. Vascular, and this is one that we don't have good markers for. So when I say vascular, I'm talking about those growth-restricted fetuses that come in that have abnormal Dopplers, and you put them on the monitor and they're contracting. There are biomarkers that are initiating this process. Uterine distension, twins, triplets, quadruplets. The more babies there are, the more likely they are to deliver prematurity. Cervical disease, we will talk a good bit about today. Hormonal issues. 17-hydroxyprogesterone is specifically designed to treat patients that have a potential hormonal issue or at higher risk, and this particular therapy seems to work. There's definitely an immunological process to this, and then there's a whole other set that falls into that unknown process, although that's becoming less and less. We're able to put more and more patients into these particular processes. But this preterm birth problem in the middle there is really mediated by a number of different processes, but those processes actually have some common pathways. And so if we're talking about inflammation, infection, we know there's upregulation of cytokines. We also know prostaglandins play a big role in that process. Decidual hemorrhage over on your right-hand side, upper right. Abruption, we know what blood has prostaglandins in it, and those prostaglandins are going to cause contractions. Stress, we know stress, whether the stress is from the mother, i.e. she's in a stressful situation, or it's the fetus, it's in a growth-restricted situation. Cortisol probably plays a big role in that. We know that cortisol specifically has a role in term labor, okay? And over-distension, once again, as the myometrium stretches, it doesn't like that process, and it's going to be more likely to contract more and more. So, but all of these really have some common pathways. And I mentioned to you the infection and specifically the decidua. Both of those two are going to have some uterotonic properties associated with them, particularly prostaglandins that are going to initiate the process. Also, pathological overdistension goes into that. Just exactly like from the proteases will be upregulated with infection. They'll be upregulated with stress, regardless of the etiology of the stress, as well as hemorrhage. And so all of these processes interact, and there's a mechanical process that takes place whenever you have contractions, and fibronectin, and we're going to talk about fibronectin, okay? And so I know you guys use fibronectin. I hope whenever you finish today, you understand why you use it and why it's beneficial. So fibronectin leaks into the vagina, and there's contractions, and ultimately that patient can deliver prematurely. So all the residents know I like story time, so let me tell you about my first time I came to know about fetal fibronectin. I actually I left here in late in July of 1990 something and moved, no, 1980 something, Lord have mercy, that's a long time ago. And I moved to California to do a fellowship at UC Irvine. And one night I was, actually I'd been there about 10 days, and the next morning I had to give a talk at a hospital there in the Southern California area. And we had a very, very, very big service, and I was doing what we all do. I was getting ready. It's 10 o'clock at night, and it was actually 9 o'clock at night, and I'm getting ready. And back then, we didn't have PowerPoint. We had Harvard graphics, and so we type it on our Harvard graphics, and then we had to shoot our slides, and then we had to actually cut our slides and put them in these little things. And so anyway, I was doing this, okay, late at night, and this guy kept walking in and out of the computer room there at UC Irvine, and the guy had on a t-shirt and some jeans, and he looked like he probably wasn't supposed to be there. In fact, I thought he probably was doing something illegal, stealing or something or another. And so this guy, after I'm already, I get everything set and my camera's shooting, this guy, I asked this guy, hey, what you doing and everything, and this guy introduces himself. His name's Drew Saunier. And Drew's a very interesting guy. Drew is from Northern California, and he went to Caltech on a scholarship, and he got a degree in biomechanical engineering. And in fact, within 4 years, he not only had a bachelor's degree, he had a master's degree from Caltech. And he decided that he wanted to be an inventor, and so he felt like he needed to probably go to medical school. And so Drew got a full scholarship to USC, and he went to USC, and he was valedictorian in his class. And then he decided, well, I probably need to do a residency because I really don't know what I want to invent. And so he decided he would do a residency, and he did a residency at UCI. And he finished like 2 weeks before I got there. So he had finished his OB/GYN residency, having never intended to practice medicine. He wanted to be an inventor. And so in 1981, there was some articles that came out in the Gray Journal about a protein called fetal fibronectin. Okay? Some Japanese discovered it. They didn't know what it did. And Drew saw it, and he thought, you know, they did some tests, and he thought maybe this is a way to diagnose ectopic pregnancies. And so he developed an ELISA for the test, and they did a study, and it didn't work. But then Drew decided, well, maybe this is going to predict prematurity. And so he was actually there working with a group of capital venturalists to do a study. And while I was there, every patient that I saw got a fetal fibronectin as part of a protocol. They had to sign an informed consent. I think they gave him some money. But at any rate, he did this. They did this study. Now, the rest of the story is, within about 5 years after my first meeting, Drew owned a DISA pharmaceutical company, and they ultimately went on to have a patent, and we'll talk more about that in just a minute, of fetal fibronectin. They ultimately went on to have the first patent on 17-OHP. Now, they've sold it since then. Drew has sold his interest for $250 million. He's never practiced medicine a day in his life. Haven't seen him for about 7 years. The last time I saw him, it was at his home in Beaver Creek. He has about a 10,000 square foot home up on the mountain at Beaver Creek. So just goes to show you I'm in the wrong business. But it is a very interesting story. And this guy got this ideal just by reading an article and having a thought process. So at any rate, while I was at UC Irvine, and Tom put this together, and it was published a number of different places, I kind of like this graph out of Contemporary OBGYN. And we basically followed these patients out longitudinally, and what we found was that in a normal pregnancy, the protein is not supposed to be there between about 22 weeks and 35 weeks gestational age. And if it's there, it changes the risk of what's going to happen to that pregnancy. Now, if it's positive, it doesn't necessarily mean that they're going to deliver, but we'll talk more about that in just a few minutes. So, with that as a little bit of a background, what is it? It's a glycoprotein. It's really super glue. Its job is to glue the pregnancy to the underlying decidua, okay? And it's made by the pregnancy, and it's supposed to be up in the uterus. It's not supposed to be in the vagina, okay? And as they're shearing, that takes place with contractions, this protein will leak down into the vagina and become positive. And yes, at term, this will become positive, okay? And in fact, let me tell you, there's at least 3 articles that show a very high positive predictive value of whether or not your induction of labor is going to be successful if this is positive or not, okay? So there's been some discussion that some insurance companies, they're not going to let you do a 39-week induction without this because it costs a lot of money to induce people, okay? So those kinds of things are being talked about right now then. So don't be surprised. So ultimately it did get FDA approval, and it got FDA approval for 2 things. The last one down there, the symptomatic patients, are what we're going to talk about today. I made a statement up there. It's the strongest predictor for preterm birth. I'm going to show you the data behind that and remind me to do that for less than 32 weeks a little bit later on. But it also can be used in conjunction with asymptomatic patients that may be at risk. And so I'm going to give you an example. So about 4 years ago, a nurse came to see me, and quite honestly, it was a very emotional interaction. She was crying whenever she came in. Her first pregnancy, she delivered spontaneously at 25 weeks. That baby actually stayed in the ICU for a very long time, but ultimately did okay. The second pregnancy, she had really no difference in her treatment. Once again, this time at about 24 and a half weeks, she went into spontaneous preterm labor and had a child, and that child ultimately had cerebral palsy and was severely neurologically damaged to the point that she really couldn't work, okay? Now, backing up, the first pregnancy she showed up, she was advancedly dilated, but they got steroids on board, and that may have related to the fact that that baby did okay. The second pregnancy was totally different in that she showed up, she was 9 centimeters, and I can't explain why her physician had seen her 3.5 weeks earlier and was not seeing her more frequently with her history. She also was not being treated with 17-OHP, but that's for another day, okay? So she comes to see me. She's upset. She did not want to be pregnant. She was using some form of contraception, but she openly admitted that sometimes she, quote-unquote, forgot to take her pill, and so we have an unintended pregnancy. And obviously she has options, but she opts to continue her pregnancy based on religious beliefs, appropriately so. And so she comes to me and she wants a plan, okay? So this is a lady that we followed serial fibronectins on, okay? So when I got her to the appropriate gestational age, we did a number of fibronectins, and yes, she had some positive ones, and yes, she got tocalized multiple times, okay, with pretty aggressive tocolysis. Yes, she ultimately got advancedly dilated pretty early, and she spent some time in the hospital. However, she went to 33 and a half weeks. She had a premature baby, okay? That baby was home in less than 2 weeks, okay? And the good thing is that she sends me a bottle of spirits every year. Not that I necessarily did anything, but that's an example of somebody who's asymptomatic, okay? Sometimes I use these in triplets and quadruplets, and so there's some specific things that I will use this on. I don't use this on everybody though, okay? It's not a free test, and part of what we're going to talk about today is being cost effective in our care. But those are examples of patients that could be used that are going to have a benefit. All right, so let's talk about the symptomatic patient though, because the rest of this talk is going to be about patients that show up with symptoms, all right? So if I ask you what you look for, or what kind of things people present for if they're in preterm labor. You're going to tell me contractions, cramping, bleeding, pressure. You may talk about cervical change. You may talk about cervical links. You may talk about fibronectins. All those things kind of come into your thought process with respect to the symptomatic patients, what you're going to see both subjectively as well as objectively. So if I went and there's a few students in the room, if I ask them what the definition of preterm labor is, what are you going to say? What are you going to say, Zach? Tell me the definition of preterm labor. What do you think?
Labor before 37 weeks.
Okay, so contractions that lead to cervical dilation, right? Okay, all right. So this is right out of the American College of OB/GYN. They totally agree with that. Everybody else agree with that? What do you think, Dr. Austin? You're fixing to be a rich private OB/GYN. You agree with that? Yeah. So that's what the American College of OB/GYN says. So I'm going to tell you that I don't know if that's right or not. Okay, I'm not going to say, obviously, if you're sitting in front of me in Dallas, Texas, that's the right answer. But the real problem with that is that there are a lot of people that have contractions that don't deliver prematurely. Okay, and in fact, most preterm labor resolves, and most people that we admit with preterm labor go home. Very few of them, 10% of them actually go on to give birth within 7 days. Okay. And so that tells me we don't do a very good job of trying to figure out exactly what's happening, all right? And so a lot of us think that we have magic fingers and we can tell. And I don't have fingers like that, okay? And so I'm not sure this is the right answer to the question. So let's talk. So why would I say that? All right, I could throw 10 articles at you. I could actually probably throw 20 articles at you, but I'm going to throw 2, okay? This first one we actually did here, I was the PI here back in the 90s on this particular study when I was here before, and it was a prospective randomized placebo double-blind controlled trial. So, and Intosubban, anybody know what Intosubban is? It's an antioxytocin. So it basically goes to the receptor on the uterus and it blocks the receptor, okay? So we all know we use oxytocin in labor and delivery, and so that's what this drug is. Now I'll tell you that I just left a place where I was the PI of another drug very similar to this that has 1,000 times more affinity for that receptor than Intosubban. This drug is the #1 drug used in Europe for tocolysis, okay? The #1 drug, and has been for the last 20 years. And so they were trying to get it FDA approved here in the United States. And so multi-center trial, I think there was 32 sites. They had very strict criteria for entrance into this study. We not only participated in this study, but there was another study that Bahasabai was the PI on that was also published at the same time. These are back-to-back articles in the Gray Journal. But this one had about 500 patients in it. And notice I put right here, I said strict definition of preterm labor. It required documented cervical contractions with documented cervical change by the same examiner. Okay? So one of the problems we all have here, and Dr. Cooper and I were talking about that just a minute ago, is that we have a wide range of people in this room with a wide range of experience. Okay? And my 4 centimeters and your 4 centimeters may be a little different. Okay? This required documented cervical change by the same examiner. And guess what? Half of those patients, despite having documented cervical change, went to term. Okay? And by the way, these people had to be over 1 centimeter to be included and over 50% to be included in their first exam, and they had to be over 75% effaced in their second exam to be included in this study. Okay? Well, you know, this is one of those prospective randomized trials. It's done at a bunch of academic centers. It's probably not right. Show me something else. All right, so here it is. All right, so this is a single center, okay? Once again, a very strict definition of preterm labor. Same person had to say that this lady changed her cervix, okay? And guess what? Half of those people went on to term, okay? That tells me that what we do or what we think is preterm labor may not be preterm labor, because lots and lots of patients show up what? They show up contracting. Okay, how many people show up contracting that we send home every day, right? Okay, so what happens is they go home, they have intercourse, and they come up to labor and delivery and sit half the night contracting, right? Okay, so, and that doesn't happen every time, but it does happen a good bit. And so a lot of patients contract, And so we know that that's not a very good indicator of prematurity. Well, what about fibronectin, and why do I kind of believe in this? And not that I believe in its positive predictive value, and I'm not going to talk a lot about its positive predictive value. I'm going to talk about its negative predictive value today. So the real benefit of this thing is not how good it predicts prematurity. We're going to talk about that, okay? But we're really going to talk about its negative predictive value. So Alan Peaceman was the primary author on this study. It was published back now 20 years ago. A multi-center observational study. These are people that showed up with symptomatic. They were symptomatic. They presented with contractions and were in labor. And every one of these patients, all 763, were admitted and had tocolysis and got corticosteroids. Okay, and these are at 5 big centers across the United States. Now, to really be able to see how well something works and what its positive and negative predictive value is, you have to have enough positive tests. Okay, and this one had plenty of positive tests. Had 150 positive tests, or about 20% of the tests were positive. And what it showed was that the negative predictive value was 99.5% for 7 days. Okay, so they were able to predict that a baby wasn't going to deliver in symptomatic women. In other words, people showing up that I'm admitting, I'm tocolyzing. Okay, almost 100% of the time. Okay? And in fact, I'm even going to go one step further and tell you that some of those people that delivered that had a negative test, one of them specifically got delivered for another reason. Okay? She got delivered for fetal indications, had nothing to do with preterm labor. Okay? So not 100%, but pretty doggone good at being able to predict that. And there's been several studies since then. Yes, the positive test does predict, but it's not by no means 100%. Okay? So the real advantage is this negative predictive value. Why? Because it makes me intervene less. Okay, and we're going to go through this as this talk goes forward, talk about the interventions that we do, the importance of those interventions, but also why the intervention needs to be done at the right time. Okay? All right, so the big thing about the test is that it helps me determine that. So what are my interventions? All right, so corticosteroids is always at the top of the list. I know of nothing else. I can't remember a whole lot that the National Institute of Health sent out a little pamphlet back about 10 years ago now then, and basically said it's below the standard of care not to use this. Okay, and at that time, despite the fact that we had overwhelming data that there was benefit, and I'm going to show you that data just on the next 2 slides. Less than 50% of babies that should have been getting it were getting it. Okay? We also want to make sure patients are delivered in the right place. You know, this is a whole topic under itself, which I'll talk a little bit about. We'll talk a little bit about tocolysis. But I never miss a chance to talk about steroids. I really want to talk about this last study down here. This is the Cochrane database. These were patients included in prospective randomized double-blind placebo-controlled trials. Okay? That's what was included in that analysis. It's about 10 years old now then. And what it showed in the 4,269 infants that got randomized to steroids, they were 30% less likely to die. Okay, that's a pretty good thing to look at, death. Okay, 35% less likely to have RDS, more than 50% for intracranial hemorrhages of various types. NEC, more than 50%. NICU admissions were decreasing, as well as early sepsis. And early sepsis was one of the things we were very concerned about early on because of the immunocompromised situation that steroids put you in. But this is data, once again, from the Cochrane analysis, so pretty overwhelming data. Here's what the problem is. The problem that goes along with this slide right here, and I don't think you can see the references back there, but these are high-quality references. But basically, this looks at the odds rate, the relative risk of something happening compared to of steroids delivery within 7 days after steroids versus 8 to 14 versus 15 to 21. And these are not percentages; these are relative risk. Okay, so everybody follow those numbers there. Make sure we're all on the same page. Okay, so if you got steroids within 7 days of your delivery, same gestational age, you were compared to 8 to 14 days, 5 times more likely. About the same for 15 to 21. RDS, big difference, okay? More than twice as likely. Chronic lung disease, 8 times more likely, okay? Composite outcomes, really no different in the 14 days, and that's the reason why the recommendations are 14 days to wait for steroids. It's based on this data right here. However, when you got to 15 days, 15 to 21 days, 7 times more likely to be worse outcome, okay? So the reason why we do rescue steroids is based on this data right here, okay? So what that basically is telling me is doing it at the right time, giving steroids 7 days before delivery makes a huge difference in outcome. I just showed you steroids makes a big difference, but if you really want to get the most bang for your buck, you want to pick out the patients that are actually going to deliver, okay? Who's going to deliver, all right? So let's just use fibronectin, okay? How many patients do I need to treat to, let's say, prevent respiratory distress syndrome, all right? So if I have a negative fibronectin, I got to treat 509 patients to prevent 1 case of RDS. Remember, everybody doesn't get RDS. What about no fetal fibronectin testing? Okay, you only got to treat 109. This actually makes what really makes sense is this one down here is the positive test. I only got to treat 17 patients to prevent 1 case of respiratory distress syndrome. So using that as a baseline, how many patients do I have to treat with mag sulfate and severe preeclamptics to prevent eclamptic seizures? About 100, okay, between 100 and 125, depending on which study you use. We're going to talk about mag sulfate for cerebral palsy. If you believe that works, how many patients do I have to treat? I have to treat about 70 patients, okay? So that's pretty good bang for your buck when you're looking at it from a public health point of view. So whether I believe this data or not, it's out there. There have been 3 very large prospective trials that have all shown exactly the same thing, that before 32 weeks of mag sulfate does decrease cerebral palsy. It's a pretty benign intervention. There are 3 different protocols, and ACOG says what? You can choose the protocol that you want, okay? That no one protocol is better than another protocol. All right, that's what the American College of OB/GYN says. One of those protocols, you just load the patient. That's all you do. That's the French protocol. They gave them 4 grams, and that's it. Okay, I know that's not what they did in Dwight Rouse's protocol from the MFMU, but that's what they did in the French study. The Australian study was pretty rigorous, and it's the one we don't follow. I'm sure you guys I know that here we follow the MFMU trial. Tocolytics, totally different talk. Do I think they work? I think they work short term for about 48 hours. I'm not somebody that uses them long term, except for a specific situation. An example is a patient that had twins that had, one baby had a hypoplastic left heart that delivered last night, and her baby weighed 2380, by the way, and is doing very well, okay. There's another lady that had never delivered past 30 weeks, and she made it to almost 35, so hopefully she'll get both babies. Very nice lady. So at any rate, I'm not going to go off into this. There's a lot of companies working very diligently to try to find something that works, but probably one of the reasons why they don't work has to do with what? It has to do with the fact that we're taking one drug and we're giving it to people with a bunch of different etiologies for their preterm labor. Does that make sense? Everybody follow that? Everybody awake? Priya, you awake? All right. All right. So how are we going to really make a big difference in this problem? Well, one of the ways is to look at standardized protocol. And when these things started coming out, I was very, very, very resistant to it. And as I've gotten older, I've realized that I don't know why I would be resistant to that, quite honestly, because it makes things easy. And it really has been shown it's not so much a lot of times the protocol, it's just following the same thing that's important. And then it's my job to do what? It's to make sure that before you get out of here that you know the exceptions to that protocol, okay? So if we're using mag sulfate for neuroprotection, then the lady that has myasthenia gravis that just delivered, right? Yeah, okay, that we wouldn't want to give her that, okay? because it's about a week before she breathes again on her own, okay? And that's usually not, it's usually a quality indicator when they can't breathe after delivery. But these protocols have been shown to do wonderful things with a lot of different things in OBGYN, okay? And so I have actually spent hundreds and hundreds and hundreds and hundreds of hours writing protocols, and I'm not going to rewrite the protocols, okay? So if you want the protocols, Joey Biggio and I from UAB wrote protocols, and you can get an app. You put in APEC at your app store, APEC, okay? That's Alabama, and I know I'm just like you guys. I bleed purple and gold, just like a lot of y'all in here, and it really hurt me to go into that state, but that's a whole different talk, okay? But you put that in there, and you download that app. It's free, okay? And those protocols were written by me, by me and Joey Biggio. Most all of them I agree with 100%. There's a couple of them that go off of ACOG, and you'll hear me talk about those, okay? Me and him really fought long and hard on the twin protocol, whether everybody needs antepartum testing. He's of the opinion that they do, and ultimately he won that, although I don't think he won it when we talked about it. He won it whenever it got published, so it is what it is. But those protocols are in there, and there's a short version to the protocol, and then there also is a lengthy version that goes through exactly the data behind every one of those points. Does everybody follow that? Okay. So there's about 30 protocols in that. And I mean, they're everything from HIV and pregnancy to immunization, all the latest data on Zika's in there, you know, gestational diabetes, you name it, preeclampsia, all those most recent things. They're not just ACOG, they're a little bit different than ACOG. There's also quality indicators because they get tracked over there on quality indicators. For payment reasons, it's going to be as of January the 1st. So this is an area that's been very, very successful, standardizing preterm labor protocols using fetal fibronectin. In fact, this is a study from the Gray Journal that shows that we could save $560 million nationwide by going to just standardized protocols with this, a decrease of 56%. All right, and I can show you how that happens. You don't admit as many people. All right, so if people need to be admitted and they need intervention, I want intervention. Okay, if they don't need intervention, I don't want to intervene for them. Okay, and I sure don't want to give people steroids and tocolytics unless there is an absolute indication. We'll kind of go over that in just a few minutes. So, you know, down there at the bottom, using it markedly decreased the likelihood that patient was going to get admitted to the hospital. And I think you guys use this some, okay? This is another study looking at the very same thing from one health system, how they were able to save lots and lots of money, almost $1 million in a fairly small system. I like this study, and there's probably 50 of these. This one's from Houston, Texas, this community hospital in Houston, Texas, where they decreased their prematurity or preterm labor admission rate by 40% in 1 year and saved $500,000. Those are real dollars, and so once again, makes sense. Plus all the work. Okay. Another thing that we don't think a lot about is most patients that get transferred to me with preterm labor go home. Okay. Not everybody, but a lot of them go home. In fact, I showed you data suggesting that 90% of them go home. All right. That costs lots of money. This actually is from Australia, where they actually have socialized medicine. So these are actual costs. So we're avoiding transferring those patients. Standardized protocols are out there. If you go to a lot of big United Healthcare, they've got tons of standardized protocols, and you're given a report card based on your standardized protocols. And yes, time spent in labor and delivery becomes a big one. Antenatal steroids is one that's used nationally now then. I think most of the big carriers track that. Most of the big carriers are probably tracking you here, okay, quite honestly, believe it or not. So let's talk about a case real quick. 17-year-old, 26 weeks, shows up contracting, has vaginal pressure, no leaking or bleeding. What are you going to do? Well, the first thing you're going to do is put her on the monitor. I hope you're going to check a fibronectin then whenever you do your speculum exam, okay? I know that we have a lot of love bugs, and so we usually do little cultures and things down there to because we need to treat those patients appropriately, okay? The big thing is do it before you do your examination. If you don't need it, and I'm going to show you an algorithm, if you don't need it, throw it in the trash. It doesn't cost the patient anything, doesn't cost the hospital anything, okay? All right, it has to be collected before digital exam, before vaginal probe ultrasounds, before we do anything. So do it first. If they're 3 centimeters dilated, throw it in the trash, or don't do it, okay? So if you see a big bag down there, throw it in the trash. You don't need it, okay? Because we're going to probably admit that patient anyway. If they've got a cerclage, there's mixed data about that, okay? In general, I don't do it, okay? I'm not going to tell you there aren't patients I won't do it on, but most of the time. Obviously, the big one is the sexual intercourse. You've got to ask them specifically about that. You know, it's upsetting to me when I make rounds and, you know, I find out somebody's in the hospital for positive fibronectin and everything's good, and then we get talking and she had sex just before she came in. It is a special swab. You need to know that. This swab can actually be collected blindly, okay? And so a lot of private hospitals have their nurses take a swab, put it in the posterior vaginal fornix, run it back posteriorly into the posterior vaginal fornix, leave it for 10 to 15 seconds, and pull it out, put it in the buffer, and send it off. Or at least hold it and see if the doctor wants to send it, okay? And the sensitivity specificity is almost exactly the same with those two things. It usually takes about 30 minutes to come back. They're about $80, okay, is what they cost now then. So it's not like a very expensive test. Your GC and chlamydia cost more than this test cost, okay? And you're not going to get the GC and chlamydia. I think you're going to get them on most of these people, aren't you? Yeah, there you go. It's because a lot of them are positive, aren't they? Yeah. All right, so if they're over 3 centimeters or greater, I'm probably going to admit that patient anyway. When I say 3 centimeters, I'm not talking about a multiparous 3 centimeters that's, you know, probably walks around like that all the time. I'm talking about 3 centimeters with some effacement. Then I'm probably going to admit that patient. I'm not going to send it. But to see other patients that potentially I'm going to use that on, okay? All right, so I'll beat that in. All right, so how do I predict what patients really need my intervention? All right. Well, I can use a couple, 3 things. So this is where I'm going to talk about cervical links, so just hang with me for just a minute. All right, so I can use risk factors, I can use fetal fibronectin, and I already talked a little bit about fetal fibronectin, and I'm going to talk about cervical links too. So these are the risk factors, and of course, all the residents know the biggest risk factor for preterm birth, one of the biggest risk factors is what? History of preterm birth, right? That's one we all get worried about, okay? And of course, we offer those patients 17-OHP, which we'll talk about in just a minute. These are all risk factors that have been around for a long period of time. We used to think that we could really use all these things and really predict who was going to deliver prematurely, and Bob Creasy did a study back years and years ago down in Houston, and he said, you know, we can use these risk factors and it works, and then 3 other people said it doesn't work, and we figured out that guess what? It doesn't work, okay? More than half the women who deliver prematurely do not have a risk factor, okay? 2/3 of the women that have traditional risk factors do not deliver prematurely. So risk factors don't work that well. This is a classic study from Bob Goldenberg, former chair at UAB, looking at some of these risk factors. And I mentioned to you earlier that all of this data is from the NIH. Okay, all this data was collected from the NIH. It represents over 10,000 pregnancies. Okay, so these are big trials and big data banks that were used to write this particular article. What about contractions? Well, we already talked they don't predict anything. So these are relative risk, and all the residents and all the students know if it crosses 1, what? It's not statistically significant, right? Everybody knows that? Okay. All right, so we'll all get on the same page here. So contractions, no. African American, no. Pelvic infection, no, with the exception of bacterial vaginosis. Okay. Statistically significant. Lots of data on it. Okay. What about vaginal bleeding? Yes. Okay. Almost 3 times higher to deliver prematurely. What about low maternal weight? Okay, this is one of those ones we actually had 2 or 3 in clinic yesterday. I couldn't believe it. I thought this was a thing of the past, but we had 2 or 3 of them in the clinic yesterday, and of course, first thing I talked to them about was what? Several of y'all were with me. I started talking to them about the risk of prematurity. Okay, when an 85-pound young lady comes in, okay, she's at huge risk for delivering early. Okay, and for having an SGA infant, though it's usually constitutional. Okay, so the big three are down here at the bottom. We're going to talk more about them going forward. Prior preterm birth, 7 times. Cervical length at 24 weeks, less than 25 millimeters, about 8 times. And positive fetal fibronectin in the late second trimester, about between 14 and 15 times, delivered before 32 weeks. Our cervical lengths, okay? I hope that everybody gets very, very used to doing this. I was on an ACOG task force to determine whether or not we should be doing it right now then. It should be standard of care. And ultimately, we made the recommendation that it be withheld. Not that the data is not there. The problem is that I've got lots of doctors out there that don't know how to do them, okay? And I can tell you, when we were doing them fairly routinely, I was getting 10 patients a week for short cervixes that had a cervix of 12 centimeters. I'm being facetious, but a bunch of long cervixes, okay, because nobody knew exactly what they were measuring, okay? So this is very important. So this is from Vince Vergella. Vince is one of the authorities on cervical lengths. There's a 3.5 centimeter cervix, okay? There's a 1.2 centimeter cervical length, okay? So let me tell you, these are 2 patients of Vince's, and what do you think the exam was on these 2 patients? Fingertip, both of them, fingertip. That's what he called both of them, okay? He called both of them fingertip, okay? Very, very different, okay? Everybody sees that? Okay. All right, so we know that the cervix, whenever it changes from the top down, okay? And that once we start getting effacement, that we're kind of far down the track. And this right here is predicting that there's a problem, okay? So this goes back to GYN's original data. Looking, this is just a Kaplan-Meier curve, survival curve, looking at prematurity based on cervical length. Your chances of delivering prematurely are not 100% even when the cervix is 0. Okay, so don't think that if the cervical length is 0, it's 100% that they're going to deliver prematurely. They're not necessarily going to, but there is a direct correlation. Everybody see that? Okay, direct correlation. Same thing with fetal fibronectin. If I check the fetal fibronectin in an asymptomatic patient, so asymptomatic, and it was positive, and I followed out a cohort of patients, and I compared positive to negative, you can see Kaplan-Meier curves, very wide variation between the two. All of these are highly statistically significant. Once again, this is from the NICHD data bank comparing these, and this is in asymptomatic patients. Okay, combinations. Okay, so there's been a lot of studies looking at this one. Once again, is from J. Imes. One study: when you have a positive fetal fibronectin and you have a short cervix, your chances of delivering early, prematurely, less than 35 weeks, 65% compared to 25% if you have a negative fibronectin, even if you have a short cervix, okay? And you can look here and see that regardless, the combination of the two, and this kind of makes sense going forward here. This is a study that me and one of my former residents wrote, Emily DeFranco. This is a multi-centered, this is a systematic review of patients that actually had symptoms, looking at predictive value of both, and you can see that there's some pretty good positive and negative predictive value compared to other things. Okay. Now, we use something called a quad screen, and that quad screen, anybody know how that got started? I tell you, I'm going to run out of time. I have another story I like to tell. You know that story? Yeah, all right. That's a good story, though.
It is. It's very interesting.
It is very interesting. So let me tell a story real quick. I may have to pop through some slides real quick. MSAFP. Everybody knows what that is? All the residents know what that is, right? Okay. So when that came to be used here in the United States, it was I thought we were crazy, okay? It actually was found over in Great Britain, and they have twice the incidence of neural tube defect that we have here in the United States, okay? They have very different population, highly Caucasian, which have a higher incidence of that particular disorder. I'm not quite done. Y'all come on in. I'm sorry. Could you give me 5 minutes, Kevin? Okay, thank you. All right. We brought it over here in the United States. Now, over in England, what do they have? They have socialized medicine. So an MSAP costs 20 cents, okay? Here in the United States, it was 110 bucks, okay? So when you look at healthcare dollars expended, it didn't make a whole lot of sense, all right? So this went on for a couple of years, and there was a famous plaintiff's attorney whose wife got pregnant over in up in New York, and she had an uneventful course. She was being followed by a fairly well-known perinatologist up there because nobody else would take care of her. She goes to term, and she delivers a baby that is perfectly normal except for it has Down syndrome. Okay, maybe I didn't say that right, Rose, but baby has Down syndrome. Okay, so obviously the plaintiff attorney gets the chart and takes a look at it, and it says something got missed. You know, she didn't have any risk factors. She's less than 35, you know, went through the whole thing. The only thing that they saw was a low MSAP, okay? And so he went back to the doc and he said, and this guy's done lots of research, and he says, could this have predicted this? And the guy goes, I don't know, maybe so. So he did the original study, or his group did the original study, looking to show that low MSAP is associated with Down syndrome, okay? There's one analyte out there, there's probably more than one analyte, and yes, there ends up being about 25 of them, okay? Now, once you get across a certain number, that the predicted value doesn't increase, but what we know is that if you have independent risk factors that are all predict an outcome, adding them together further increase the predictive value of that. Does that make sense to everybody? Everybody follow that logic? Maybe I didn't say that right. But anyway, you take cervical length, you take prior preterm birth, you take positive fetal fibronectin. If you have all three, your chance of delivering prematurely is over 60%, okay? And I'm going to skip this real quick. We have something else to do. Debris. You see that debris right there? How many of y'all, we have somebody in the hospital right now that has some of this, okay? All right? So what is that? If we aspirated that, you'd find neutrophils out the wazoo. You'd find macrophages out the wazoo. You'd actually find bacteria out the wazoo, okay, in the amniotic fluid, all right? So that's a bad outcome right there waiting to happen. And in fact, this is an abstract, and George Soddy still hasn't published this, but he went back to Imes's original trial and reanalyzed the data and broke them down into either those who had debris and those who didn't have debris. And what he found was that cervical length didn't even predict prematurity unless there was debris present, okay? So it's probably infectious in origin is what's going on. And I wore him out for not publishing this because I think it's good stuff, okay? I'm going to talk about one more thing, 2 seconds. Short cervixes. If you find a short cervix in an asymptomatic patient, there are 5 prospective randomized trials that all predict the fact that by giving the patient vaginal progesterone, that it prolongs the pregnancy, and it's pretty significant. It's over 40%, okay? And I think this is something that we kind of started since I got here, okay? All right. In fact, ACOG has a practice bulletin out. This is category A recommendation. In fact, we did 2 studies here that showed this. 2 of those trials I'm on, okay? We did them over in that clinic, all right? And so this is currently standard of care for less than 20 millimeters in asymptomatic patients, okay? In singletons, there's actually data in twins too. So, but I'm not going to get off into that. Definitely no 17-OHP in twins. So we have some visitors today. So if everybody will just hang with me for 2 seconds here.